It is absolutely delightful to introduce Dr. Guillaume Fontaine, who's an assistant professor at McGill University. And Guillaume is going to present on implementation science to address policy barriers to the scale-up of NSPs from evidence to action in 12 months. Thank you very much, Guillaume.
Great. Thank you so much, Jackie, for the warm introduction. We're very lucky to have you as chair of this session because Jackie is super energetic and will keep us entertained, I'm sure. So my name is Guillaume Fontaine. I'm an assistant professor at McGill University, an implementation scientist. I work within two national networks in Canada, one focusing on hepatitis C, where I co-lead implementation science, and I also co-lead the methods think tank in the CIHR Pan-Canadian HIV/AIDS Clinical Trials Research Network. So what I do is primarily focused on applied implementation research to improve STBBI care, but also improving methods in implementation science and evidence synthesis. So here are my disclosures. So I'm going to talk today about, and I wonder if we could make maybe the presenter view a bit more so I can see my slides, because now it's a bit tiny in the corner. I'll be presenting on, thank you so much. So I'll be presenting on some work we conducted with INSU, with different people that are in the room, on the scale-up of needle and syringe programs using implementation science. So I'm sure that many of you are already convinced of this, but there's a real need to scale up needle and syringe programs, and we have multiple implementation gaps, especially in low and middle income countries. It is estimated that 4.8 million people recently injected drugs, and that was 2021, who face, of course, high HIV and HCV risk. We know, leveraging different sources of evidence, that needle and syringe programs are effective and cost-effective, especially combined with opioid agonist therapy. Yet only around 2% of people who inject drugs live in countries with high coverage of NSPs, and 62% of people in low and middle-income countries have no access to NSPs. And of course, this has a range of consequences, including avoidable infections, outbreaks, deaths, and widening inequities. So we know that, the evidence behind NSPs is there, but we have an implementation gap, right? The policies are not as effective as we would want them to be. The rules as well surrounding the provision of care and the funding pipelines are not aligned with need. There's also some problems around forecasting demand and supply for NSPs and procurement problems as well. So this project really aimed to address persistent and systemic barriers to the scale-up of needle and syringe programs from a policy perspective. So about a year ago, INSU convened a multidisciplinary working group to look at enhancing collaboration between different stakeholders to resolve those issues. And at that stage, we were brought in as implementation scientists to help support those activities and to leverage implementation science to help answer what works for whom in which context, and really how to optimize scarce resources. The goals that we had were to really use an implementation science-informed consensus process to look at the key barriers at different levels to scaling up NSPs. So really looking at three different levels: global policy barriers, national policy barriers, and procurement problems. And then map and further develop some of those strategies and look at potential outcomes of those strategies as well, and what would we want them to achieve and what success looks like. We use different frameworks from implementation science. I won't go into much detail about those, but we use a framework called the Consolidated Framework for Implementation Research to look at barriers and facilitators. We use as well an implementation strategy taxonomy, so a list of implementation strategies to look at what could be the strategies to support the scale-up of needle and syringe programs. We used a tool called the CIFER and ERIC matching tool that helps match appropriate strategies to barriers, and we also used a framework from Enola Proctor in the US to operationalize the strategies that were selected. In terms of method, so the INSU working group was composed of 26 different participants, purposive sampling and snowball sampling across different roles and regions, including individuals with experience in policy, financing, service delivery, procurement, supply chain, legal and policy reform, a lived and living experience leadership with some researchers as well. And then the second stage of sampling was really the participants that were attending the INSU Policy Day workshop at the last INSU conference in Athens, where 54 participants were involved across the different WHO regions, as you can see in Table 1 that's next to the text. And the composition of the group in Athens was really different multilateral agencies, WHO, representatives from Global Fund, UNAIDS, academics, peer and community-led networks, as well as community of people who use drugs. The methods that we use for the consensus process, so it was a two-stage implementation science-informed consensus process using modified nominal group technique. So we preserved the structure of nominal group technique and the independent scoring aspect, so people involved in those activities could independently score barriers and strategies and so on. But we made some changes to the methods to account for a dispersed policy audience with asynchronous idea capture, multi-criteria scoring of different barriers, virtual polling, and also use of frameworks and action planning phase during the INSU in-person workshop. So the first stage of what we actually did was the generation of barriers, which was primarily asynchronous and through different conversations, and then the list of barriers to the scale-up of needle and syringe programs across different levels, so going from organizational level to policy level, were then coded to the CIFR to look at what were the constructs related to each of those barriers. And then we had a live discussion with the working group to rate the severity, reach, feasibility to address each barrier, but also positive knock-on effects if we were to address a given barrier. And also participant described what success would look like for each barrier as well. And we calculated composite scores for identifying high priority and high feasibility barriers. The stage 2 was the in-person activities at the last INSU conference. So with 54 participants, as I mentioned, we had 6 tables, around 9 participants each. It was around 4 hours in duration. And really what we did, and I'm going to show you a bit later, the strategies that we developed is for each of those barriers, what could be some ideas in terms of strategies to address a given barrier, and then strategies were selected and fleshed out. So for example, if there was a lack of political will in a country to scale up needle and syringe programs, that was mapped before the in-person workshop to the construct external policy and incentives of the CIFR, and then asynchronously before the workshop in person, we as implementation scientists working, including with Natalie, mapped some potential strategies to address those barriers that were brought in the in-person workshop. And then we used, I'm going to present to you the different barriers that were prioritized. So in the end, we have a total of 15 barriers that were identified across global policy, national policy, and procurement domains. And 6 of those barriers were prioritized via composite scoring. So I'm going to talk a bit more about the 6 barriers that we prioritized. And across all activities, that led to 11 strategies being developed to address those 6 barriers. I'm not going to go through all of those 15 barriers. I'm going to focus on the 6 main ones. To prioritize barriers, just to show you a bit more how we actually did the process, is that we had a composite score based on severity and widespreadness of the barrier, geographic, demographic impact, extent of positive knock-on effects, like I said, if the barrier was fixed, and also the feasibility and the effort needed to address each barrier. And this was, a composite score was calculated, and it was mapped on different matrices like this. So those were the global policy barriers, and we did the same exercise for the national policy barriers and the procurement barriers. So in the end, those that were selected, had a composite score somewhat in the middle, right, with a pretty high severity and also high feasibility. And then briefly, how we developed the implementation plan for each strategy was around fleshing out who actually needs to do what. What are the roles and responsibilities for each strategy? What is the timeline of action? What are the resources that are needed? What are the intended outcomes? And why did we select the strategy in the end? So this is the whole figure, pretty much, of what we developed across the different barriers and strategies. So as you can see in global policy, the first one that I'm going to talk a bit more, we have 2 barriers. So no global guidance on community-preferred communities for NSPs, and also, sorry, I'm not seeing quite well on the slide, but funders restricting support for harm reduction. But I'm going to go through in a bit more detail how we fleshed out those barriers. So what we did is, we have 6 barriers and then 11 strategies, clarifying intended outcomes, but also clarifying who are the key actors for each of those strategies as well. So in terms of global policy, the first major barrier that was prioritized is the absence of guidance on community-preferred commodities, and which means that countries often default to cheapest or familiar items, like having a really narrow catalog of commodities, which can really compromise safety, acceptability, and uptake of NSPs. And by community-preferred commodities, we mean having a mix of syringes, syringe types, and low dead space options, prep filtration, disposal kits, discrete packaging, sufficient volumes to support distribution, and so on. Second major barrier was that some global funders would restrict support for harm reduction, and that really translated to NSPs sitting within HIV budget lines without a distinct coverage indicator or budget, and that can weaken accountability for coverage. So the strategies that we developed for those barriers, the first one was engaging people who use drugs to co-develop commodity selection procurement guidance. We, across the group, thought that this would lead to revised guidance and improve the relevance and acceptability as well. The second strategy was to require values, preferences, and demand data justified in requests for funding to the Global Fund. The third and fourth strategies, the first one was really to advocate for adoption of harm reduction as a standalone funding priority, leveraging the 2024 Commission on Narcotic Drugs resolution, and it's titled Preventing and Responding to Drug Overdose Through Prevention, Treatment, Care, and Recovery Measures, to have dedicated funding and more stability. But there was also a need that was recognized among the participants to have knowledge-strengthening programs and efforts for global funders to really advocate for the evidence on harm reduction and raise more awareness and support as well policy shifts. So those were the barriers and strategies for global policy. For national policy, and also, across the different strategies and barriers, I would say maybe half is applicable primarily to low and middle income countries, and about half of the strategies and barriers are applicable across both low and middle income and high income countries. But the first one in this group being a limited political will and funding, and that's really applicable across country income levels, often reflected in the absence of ring-fenced budgets or donor requests for NSPs, which can constrain implementation and scale up of those NSPs nationally. But also some restrictive rules and limiting service access in NSPs across different countries, so like identification mandates or one-to-one exchange rules, visible policing near services that can depress coverage and deter attendance to those services. So those were the 2 barriers in this group. In terms of strategies to address those barriers, the strategy 5 was really to have coordinated multi-stakeholder advocacy to secure national NSP funding. And the second strategy was to do some consensus building activities with different stakeholders in each country, among government, providers, international organizations, and community, to have some consensus statements on commitments, timelines, and really stronger political commitment. And the 7th strategy addressing the restrictive rules limiting service access was really to have national guidelines to have less restrictive access to NSPs and more permissive service models, like peer delivery, vending, dispensing machines, streamlined registration processes, and so on, leading hopefully to greater accessibility of those services. And finally, the 2 barriers that were prioritized for procurement was the fact that many of those requests, the number of, the quantity of commodities was too low to achieve WHO coverage targets in many countries. And that leads to, that is often linked to weak quantification and problems in planning, really, how we need those commodities. The second barrier in this group was the fact that the procurement processes at a country level often do not prioritize the appropriate equipment. So that might mean, community acceptable equipment or community preferred, but also quality equipment, which can lead to stockouts, rationing, but also can undermines safe coverage levels. And the last strategies, so strategy 8 was around the need to develop a quantification tool aligned with WHO and their templates to support accurate commodity requests for NSPs. And also having targeted training on how to use the WHO needle and syringe program, operational guide, and quantification processes. And then for the last barrier, it was about, primarily in low and middle income countries, for strategy 10, to engage suppliers and procurers to set quality standards and benchmark pricing for community preferred products. And the last strategy was to develop a community-led values and preferences tool with funded technical assistance that would be able to be used across different processes for demanding support for NSPs. So those were the 11 strategies. We also looked at, mapping what could each group of stakeholders do over a relatively short time frame. So in terms of, for example, global funders creating dedicated harm reduction budget lines that are not linked to HIV, for example, and requiring preference-based justification for commodities when those requests are made. And of course, we know that governments need to do a lot as well in terms of having those targets for coverage of NSPs and having guidelines to remove those restrictive access rules. Then we had some recommendations for procurement agencies, implementers as well, community networks, specifically around co-leading the drafting of those guidelines for permissive service access models and validating those procurement plans and being involved in the development of those the community values and preferences tool. And researchers and clinicians, of course, have a role to play in the evaluation and having contributing to the development of policy case studies. INSU, of course, has developed and published an amazing report on this, led by Emma Day and the team, so you can look it up. And we have an upcoming paper that's just been accepted in Lancet Global Health, a health policy article outlining all of those barriers and strategies and with more detail. And each of those strategies as well is found in the report with way more detail than what I've just presented. So I encourage you to look it up. So in conclusion, we have really an urgent need for coordinated action across global, national procurement levels to strengthen and expand NSPs. We've heard among the grapevine that there's already some policy traction with WHO and Global Fund, updating potentially some NSP-related guidance related to this work, so that's great. Hopefully we hear more about this. But there's also some evidence priorities, especially in low and middle income countries where I didn't speak to those barriers, but of course there's many organizational level barriers and service level barriers to address in scaling up harm reduction programs, including needle and syringe programs, and we really do need better and more context-specific implementation research to look at what do we need to do to have sustainable models of care in those settings. And yeah, the bottom line is that tackling these barriers is essential in conjunction with the policy level barriers to achieving high equitable coverage of services responsive to the needs of the community. So thank you to the team, many people who contributed to this work, members of the INSU Policy Day Working Group as well, and thank you for being here.